Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Welcome, everyone, to Clinical Pearls and Combination Therapy in Acne. We are going to get started. So, Dr. Baldwin, we always learn from you. Thank you so much. Thank you so much for being up here in the hot seat. We're going to have a very lively panel discussion on acne, one of our favorite subjects. And you've done such a good job educating us on the 4 pillars of acne pathogenesis. Of course, they are in order: follicular hyperkeratinization, excessive sebum production, C. acnes, and inflammation.
Right.
But you mentioned something this morning that was so interesting, that not all C. acnes bacteria are evil.
Yes.
Can you explain those phenotypes?
I shouldn't have used the term evil. There are 3 subtypes of C. acnes. Type 1, which is associated with acne. Type 2, which is associated with healthy skin. And type 3, which isn't associated with the skin at all. So the concept is that people with acne have an abundance of the type 1. People with no acne have an abundance of type 2. And wouldn't it be lovely if we could figure out a way to make the healthy even healthier and the bad guys die individually, so that we can maintain the good aspects of C. acnes at acidifying the skin and helping to reduce Staph aureus colonization.
So let's kind of rewind back to 2022, 2023, when you first heard of the rationale behind triple combination therapy. So how did you feel about it, having a combination benzoyl peroxide, clindamycin, and adapalene topical? And how does it really compare to what we've had in the past? Because we've had double combination therapies for quite a while.
Right. Well, we've been talking about a triple for maybe 20 years. It was always on the top of our wish list because we all liked the combination. We wanted to be able to use all 3 of them, but it was just too daunting. Patients didn't like using 3 medications or 2 medications if you did a duet along with the singleton. And when you give the patient a chance to choose between 2 medications that you ask them to put on, often they don't do anything, or they do one and not the other. So the triple combination gave us the maximum medications that we really wanted to use, fulfilled the 3 pillars of the 4 pillars of acne pathophysiology, and then we were also hoping for good tolerability, and we got it, luckily.
Absolutely. What does the clinical trial data tell us about efficacy and how soon patients might see results? We now have had some clinical experience with this triple combination product. Have you been surprised, and have you been excited to see that it followed the path of the clinical trial data?
Yes to both. Frankly, when we heard that they were going to have only 150 patients in each arm of the 5-arm study, we were concerned. We weren't altogether sure that, after all, the adapalene concentration had been halved. And yes, benzoyl peroxide went up a little bit, but they had cut the adapalene in half. And frankly, we were worried that the combination of adapalene benzoyl peroxide, that the triple might not be able to beat that one out in particular. Completely wrong. The phase 2 trial showed us that the triple was head and shoulders above each one of the duads or dyads, however you say it. And yes, totally surprised, to the tune of 53% success. And then you asked about the speed. Just crazy, 40% reduction, almost everybody better in only 4 weeks. So not only giving an excellent reduction, an excellent improvement all told at the end of 3 months, but an excellent improvement in as early as 4 weeks. And now we have a longer term study that shows continued efficacy after that phase 3 trial. So it wasn't even done yet at the end of 3 months.
So when you're looking at the patient profile, right, we all have our particular patients where we'll prescribe certain topicals. What is the patient profile for triple combination single agent therapy, and who's not a candidate for this topical?
Well, my typical patient is anyone who walks in the office with acne.
That's a good answer.
Honestly, and the only contraindication I can think of is perhaps pregnancy or actually being allergic to one of the components. We were hoping for efficacy, we got that, but then we were hoping for tolerability, and we got that too. So Why wouldn't I use it in all of my patients who need a topical therapy? So, everybody always asks, what's your niche patient for this particular product? My niche patient is everyone.
So, talking about tolerability, I agree. I found this product to be very tolerable, and even patients who are quite irritated by a lot of other
Mhm.
benzoyl peroxide products can also have good success with it. But do you have any tips or pearls for improving tolerability just as a whole for your acne patients, especially when it comes to retinization of the skin? Using moisturizers, application timing, barrier repair support, that sort of thing. What is your spiel, and how do you
Right.
counsel patients?
Well, I'm a little old school. Back in the dark ages, we told our patients never to apply retinoids on top of a freshly washed face. So that's still my mantra. I prefer for the skin to be fully dry before it's applied. Then you can reduce irritation by using a moisturizer either under the product or over the product, of course, a very well made one. If it's going under the product, I want it to be very light and lotiony, not containing a lot of grease, because I'm afraid that's going to block the penetration of the medication. You could start off every other day if you want, but honestly, the irritation is mild. It's going to be gone very rapidly, and I ask my patients to just gut it out. No pain, no gain. Within 2 weeks, this is going to be gone, and you're going to be happy that you persevered and got through it. I think if we talk too much about irritation, the patient gets a little tiny bit dry and stops using the product, and we don't want that to happen.
Get it out. I like that. So, antibiotic stewardship, let's talk about it. It's been a
Okay.
big topic over the last several years.
Hmm.
I certainly find myself leaning away from oral antibiotics in
Yes.
clinic. What's your approach when it comes to using topical antibiotic therapies? How do you reduce the resistance in these agents?
Yeah, so my biggest problem in that regard is when a patient comes in, this happens a lot, comes in from usually a family practitioner on minocycline and topical clindamycin. And they're wondering, why didn't they get better? Well, gosh, I think I know the reason, right? So I don't like topical clindamycin as a standalone. In my opinion, topical clindamycin should only be used when it's in the same bottle along with benzoyl peroxide. The benzoyl peroxide acts as a treatment, of course, for the acne, but also prevents the development of resistant organisms to the clindamycin. When we allow them to use it separately, I've had lots of people say to me, well, I'll give the prescription for clindamycin, but then I'll send them to the pharmacy for benzoyl peroxide. Studies show they ain't going to the pharmacy. They're not buying anything. If they do, it's frequently not benzoyl peroxide. And they're bringing it home and realizing that that cheap benzoyl peroxide causes irritation, bleaches their fabric, and they stop using it. And now they're using clindamycin. That was not your intention, but that's frequently what ends up happening. Did I answer your multi-part question? Never ask me a multi-part question.
You always do. Yes,
Okay.
and um, you and I both know, as we all do, that those two ingredients don't always play well together,
Right.
clindamycin and benzoyl peroxide. So I have a follow-up question.
Okay.
Um, how do we know that products that are put in the same bottle will play well on the playground together? And do you agree with the compounding of these two
Ooh,
ingredients?
a soapbox issue for Hillary. Yes, benzoyl peroxide is a very potent oxidizing agent and can really wreak havoc with the ingredients with which it's co-applied, much less in the same bottle. So, in the triple combination, obviously, this has been studied. They have an expiration date there on purpose for a reason. And we know that if you follow the rules along with the expiration date, that the clindamycin in particular is still up to snuff at that date. Now, compounding, don't get me started. So I'm adamantly against it. They do no studies. They have no proof. The only thing they have to do is have the concentration correct. Other than that, you have no idea. What's the vehicle? Have they tested to see that in that vehicle they're compatible in the container. You know nothing about that product, and the small amount of money that you save is absolutely not worth the increase in tolerability problems and the decrease in efficacy. Because as we said, we all said the same thing. When we saw that they were only having 150 in each group, we were worried. There is something special about the vehicle of the triple combination. I call it the special sauce of the preparation that makes it more effective than the individual's agents should be. There's a true synergy here that I can't explain, and I'm quite confident cannot be accomplished with a compounded product.
Right, you guys heard it here first. So let's talk about patient adherence and compliance. I think this is probably the biggest issue, at least for me and my
Yes.
acne patients. So when it comes to convenience, obviously, I think I know the answer to this, but having a triple combination single use monotherapy agent, does that seem to drive compliance and does that lead to better outcomes in patients?
Yes, and they have data now that demonstrates it. That I mean, it's not a shock to know that patients prefer to use one product compared to three, but they compared three separate products to a two and a one compared to the triple, and the compliance rate dramatically higher, of course, with the one use of the triple combination, which did translate into improved efficacy. So we are seeing an improved use of the product and improved efficacy as a result of that. You know, we have plenty of studies that show that that the patients fail the primary non-adherence, which is they don't even bother to go out and buy it, and then an additional group of people fail the secondary non-adherence, which is that they brought it home and now they're not using it. And you put those two things together, and the more drugs you give them, the less likely they are to use anything.
That's so true. Talk to us about the acne pipeline. I know
Oh,
you've
dear.
spoken on podium about a lot of very exciting sounding things like spongilla and bacteriophages and acne vaccines. Oh my. What are you most excited about? What do you think can help us when we already have a pretty effective product out there? And what do you see yourself using in the future?
You know, I think the pipeline looks rich, but I'm not overly enthusiastic about any of it, to be honest with you. The vaccine is very far off. The chances of it succeeding and coming to fruition is complicated. I mean, I couldn't give it a percentage, but I'll be surprised if we end up with an acne vaccine. And of course, it's only going to help the moderate patients to not become severe. The spongilla, I still think it's a monster movie. You know, the green sponge going through. It sounds very interesting, and if once a week, if that works, and you only have to use it once a week, that's quite awesome. So I think I'm excited about that. And then the oral sebum inhibitor, maybe that will be helpful, but we already have oral sebum inhibitors. Topical sebum inhibitor, I think, is a better bet. All told.
So, with this triple combination therapy, kind of a final question, what's been the most surprising benefit or maybe unexpected benefit you've seen with your patients?
Uh, the most unexpected benefit is that I'd have to say easily 9 times out of 10 when a patient walks in the room and I think, well, they really need oral antibiotics in order to get clear. I don't have to use oral antibiotics anymore. I had to fight that urge because the urge is give them a prescription for doxycycline along with the topicals and they'll get better. But, you know, the data shows us that in 4 weeks, there's such a dramatic improvement that I now wait for 4 weeks to see if the triple is going to do the job before I consider adding something to it. And I didn't anticipate the speed of improvement. And again, you know, going back to the compounding, I think that has something to do with the special sauce. I can't explain it any other way. So I think it's a sort of a can I say dream come true? I know that's an overstatement, but I waited for this for 20 years. You know, those of us in the acne mafia don't have much in our minds other than acne, and this was really at the top of the wish list. So I'm very pleased.
The acne mafia has certainly been very pleased the last couple years with our acne topical therapy
Yes.
options for sure. For those fellow derm APPs, nurse practitioners, and PAs out there that are really struggling to get their acne patients clear, what key advice would you give? Because you are such a guru and we all learn from you always, and we appreciate you so much. What's your best advice?
Well, best advice is triple combination plus a topical sebum inhibitor is an awesome combination made in heaven, in my opinion. Try to avoid oral antibiotics. Do your best to encourage adherent behavior. Studies have shown that actually confronting the patient who you know is being non-compliant is actually helpful in improving compliance, although I don't do so with the parent in the room. They end up bickering between them. I put it on every day. No, you don't. Yes, I do. No, you don't. So I ask mom to step out, and we have a frank conversation together, starting off with me saying, I know you're not using your medication every day. It's actually, it's quite helpful. So encouragement, taking photographs, because they always come back and say they're no better. And say, really? Did you see this? So I think that's quite helpful as well.
Those are some amazing pearls and amazing help for all of us who treat acne. Thank you so much for your time.
My pleasure.
The enduring content of this episode is sponsored by Ortho-Dermatologics.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.